Hello, I'm Michel Battye and I'm the manager of the European reference network that we call EUROGEN, which deals with rare urogenital diseases and complex conditions. At the moment, we're currently a network of 56 healthcare providers in 20 member states. And EUROGEN is one of 24 European reference networks created and funded by the European Commission in 2017. And they all aim to improve care for patients with rare diseases. So what do we do in EUROGEN? Well, our aim is to deliver quicker specialist evaluation and more equitable access to high quality diagnosis, treatment and care for patients with rare urorectogenital diseases and complex conditions. So they're all conditions that need highly specialised surgery, so where the expertise is rare. So some of the activities of our network, I hope you noticed from the slides at the beginning, we conduct virtual cross-border MDT discussions on complex cases. So we can bring together different experts from different countries and provide advice. This is free. So I really would strongly encourage any healthcare professional with any tricky cases who would like to contact the network, please do so via our website and we'd be delighted to help. So along with the virtual consultations, we also do education and training activities like this webinar series. And then we also write clinical guidelines and other clinical decision support tools in the rare and complex areas. And then finally, very exciting, we are pulling together a patient registry. This is being rolled out now across all our healthcare providers and about half are already entering data. This is very exciting because we know that one of the problems for patients with rare diseases is fragmented and scattered data. So we really hope that the registry will be a rich source of research in the future, and it will also provide evidence for our clinical guidelines. And then finally, I want to end with the EUROGEN textbook, Rare and Complex Urology. Please buy it. It's available from Elsevier, and there's a wonderful chapter in there written by our patient representatives, who are at the heart of quite a lot of our activities. So, without further ado, this evening's webinar is a part of our colorectal webinar series, and it's about anorectal malformations and sexuality, and it's part 2. So there was also a previous webinar on this. We always like to thank our collaborators, and in this case for this webinar, it's EUPSA and the ARMNet. So thank you very much for their continued support. The presenters this evening, we have Michel Haanen, who is a representative of a patient advocacy groups, 2 in fact, one on anal atrasia in the Netherlands, and the other one is Soma in Germany. And then also with him tonight, we have Irene Schokker-van Linschoten, and she is a nurse practitioner at Erasmus Medical Center, Sophia, in Rotterdam in the Netherlands. And tonight's webinar is aimed at healthcare professionals and patient groups, and this one actually is not accredited. So thanks to our presenters. Irene, I give you the floor, and I hope you enjoy this excellent webinar this evening. Thank you.
Thank you very much for the invitation to talk here this evening. I'm going to share the screen.
Perfect.
Yes, okay. Again, a hard name to talk. Irene Schokker-van Linschoten. I'm a nurse practitioner in Rotterdam. And thank you again for the invitation to talk here this evening. I do not have any conflict of interest. And like you already say, we are part 2. The first part was by Marieke and Stefano, and this was a very interesting presentation. And we'll not have seen it. A tip, watch it. Michel and I would like to discuss the more practical side of sexuality. And so I hope you enjoy it. why do we have to talk about sex? And is it our responsibility? And then again, how are we going to do that? That's always a difficult part. People say, I don't like to talk on this topic on my patients. So I hope to convince you that we are going to do that. Sexual health is a human right. Since the 90s, the World Health Organization says this, but the government can achieve without the help of the healthcare. So the definition of sexuality, you can read here, but it's not only about sex. If I say I talk about sexuality, people think only about sex, but it includes more than only sex. And Marike also told this studies in April in the presentation, but I also mentioned it again because this has resulted in next steps I told you in this presentation. This is a research from Desiree van der Hondel. It's almost 10 years ago. She includes 70 patients with anorectal malformation and also 36 patients with Hirschsprung disease. And like you see here, they have problems in sexuality, like erectile dysfunction, sexual dysfunction, and sexual distress. And also Marike Witvliet, she did a research about sexual function and it's impaired with the normal population. And psychology factors are correlated with sexual functioning and distress in adulthood. And the most important thing, what I learned about this research, is that 60% of the people, they want information about sexuality and they didn't get it. So, and from who they want it, they want it from the healthcare providers. So after this promotion from Desiree, we start to give our patient information about sexuality. But that's always the question is, how are we going to do this? And what is the right way to do this? And we can think as healthcare providers, what is the right way? But the best way is to ask patients. So to do this, we work together with the medical hospitals in the Netherlands, but also with the patient associations with the anorectal malformation and Hirschsprung disease. And we had discussion groups with surgeons, sexologists, nurse practitioners, psychologists, stoma nurse, pediatric doctors, urologists, and gynecologists, but also the patients. We had a lot of interviews. And looking to all the results of this interview, we made a website. And last year we also translated in English. So now hopefully more people can see and join the website, because it's also for healthcare providers to learn how to talk about sexual things. But sometimes if it's hard to talk about sexuality for healthcare providers or for the young adults themselves or for parents, you can give only this website, and it's to begin to talk about it. And you can say, okay, this is a website, you can look on it. And if you have any questions, you are always welcome with me. So I all invite you to look at this website. And if there are necessary to translate it to another language, maybe we can do that. But it's important if you talk about sexuality that you know the normal development of a child. Because sexuality, I get often the question, when do you start to talk about sex? But sex is one part of sexuality, and the sexual development is starting from a very young age. So it's important that parents know in early stage that we will talk about sexuality and not only wait till they're 12 or 14. So if they know that, it's easier to start a conversation about it. And if you want to talk about sexuality, you have the knowledge of a normal sexual development in children. And in the next slide, I will show you to them. So in the age of 1 to 4 year olds, it's all about psycho contact and learning about your own body. And we all know that when they are for the first time in the hospital, parents have stress. They didn't expect that our child will be in a hospital. And then we say, okay, you have to give your child or rectal irrigation, or we give them Hagars for dilatation. And it's a really private thing. So talk with parents how they feel about doing that with their child. Because sometimes they are not there to talk about it, and then they don't want to talk with their parents about it, or if a child with anorectal malformation is born, they don't say easy, okay, my child doesn't have an anus. So it's a taboo question, and that can hurt the child also. So talk about this uncomfortable thing. And dirty words, a 4-year-old love them and they laugh about it. But if they have to give themselves irrigation of catheterization, then they talk a lot about poop and peeing, but it's not funny words. So maybe in their class they will laugh at it, but at home it's not funny. And in the age of 46, we learn rules. So not playing outside naked, and not talked about everyone about your stool. But also in anorectal malformation, that can be different, but the doctor can always ask, how is your stool? And how many times are you doing it? And parents are asking, do you have a stool today? And playing doctor while you are wearing a diaper and your friends are not, or you have scars and your friends not. So, and maybe children have questions, am I different? And you have to learn to talk about that. And from 6 to 9 years old, you can see the first butterflies, and they learn that your body is also something to have pleasure with. And also it's the age to compare with each other. How is your body looking? And am I too big or am I too small? And if you then have something that is different than your friends, it's good to talk about it. And from 9 to 12, they are almost adolescent. And sometimes they are a child, and sometimes they think they are an adolescent. The door of the shower at home must be closed, and they are curious for sexuality. Some children will have their first courtship, and their bodies are starting to change. And it's also a normal age that we talk about doing things alone. So if you give yourself irrigation, it's good that the child is going to do that and the parents are a little bit far away. And they learn that it's more normal that they do that for themselves, and they have a private room to do that. Adolescent, good luck to all the parents. They want to be independent, but they cannot be independent on all the things, but they think they are. And how are you going to see your child suffering? Sometimes they have to give themselves the irrigation or catheterization, and they want to make their own decisions. But what if they don't want to give themselves the irrigation? You have a lot of discussion, but it's also their right that they have to be independent on the end. So we have to encourage that. And then 15 to 18 years old, almost an adult, they have the experience with relationship. And what you see in the Netherlands, the average age to have sex is going higher and higher. In 2012, it was 17. And 2 years ago, we did that research again, or in Holland, the research was done again. And now it's almost 19 years old that people have the first sexual experience. But also for anorectal malformation sometimes it can be a big thing. Are you there to sleep with someone? What if you lose a little bit stool? Maybe he thinks I'm not smelling well. That are things you have to discuss with your patient. So ask that, and be free that they can ask things things about this, and that it's good to discuss about this. But it's also the age that they not always want to talk with their healthcare provider. So you can send them to the ERN, the patient representative groups, and they have peer support. Here are a couple of problems that men with anorectal malformation can have. So they're not feeling comfortable to enter into relationships. They can have erectile dysfunction, losing interest in intimacy, afraid to pass wind or stool, negative self-image, and post-traumatic stress disorder. And also for the woman, it's a big list. Veganism, pain during sex, and also the birth is a thing that you have to discuss. But how can we help? Let your patient know that they can talk about this problem with you and ask if they have experienced problem. Build yourself a network of specialists who have experience with anorectal malformation. Frequently used specialists are the pelvic floor, psychologist, a sexuality, urologist, and know where to send them to, but know also your own limits. And on your own limits, you can send them to another professional. And because sexuality problems can also be later in life and it not stop when they are 18, because in another relationship, other things can happen. You have to make a transition plan and organize the adult care. So a couple of basic tips to talk about sex. For all of us, it's hard to start talking about sex for the first time. Or personal shame plays a big role. And being aware of this feeling is making the first step. Know your own standards and your own value. And as patients entering the room for the appointment, and you directly ask him if his erection, everyone will know that you're doing wrong. So start the conversation with a more general topic and tune your language with the patient choice of words. Patients always have their own word for their penis, or they use dick or the cock. So choose the word that the patient wants. Because using the same words makes the conversation easier for the adult or for the adolescent. And explain always why you ask intimate question. It's not for your own curiosity, it's just to help him. And then a little bit about transition, because it's a hot topic, but also it's necessary for sexuality because it's not stopped when they are 18. And sometimes you only can mention it before, and then the real problems are coming after they are turned 18. So what I mean with transition of care is of course when children are going to the adult part, but it's not only the movement, but the whole package deal. For giving them information, talk about sexuality, and make them confident they can do that. In Rotterdam, we have a timeline, and on the adult, I see them on 3 moments, on 12, on 14, and on 17 years old, and that's the moment when they come with me. And sexuality is one thing I will discuss in this appointment. It's not the only thing, and not only talk about sex, but also give information about their disease, what they feel about their body, are they drinking alcohol, what are they doing with the bowel movement. So it's a whole package deal, and sexuality is one little piece about it. And then also in Ernica, sexuality was a thing. Consider the time I'm not going to show it to you, but on our Ernica YouTube session, you can see this video about sexuality in all congenital anomalies. There's not only anorectal malformation, but I think a lot of children who are born in the hospital and in lifelong care need a little bit conversation about sexuality. So I hope you will see this video in another moment. The take-home message. So I hope after this presentation you all are going to talk about sex. Maybe you find it hard to start a conversation, but think or imagine how hard it will be for your patient to talk about it. So it's our responsibility and we have to take care for our patients. So build yourself a network, work on transition of care and adult care, and talk. Good luck. Thank you.
Yeah, perfect.
Okay, thank you. Okay, like I said, thanks for the invitation. I'm Michel Haanen. I'm a professional family counselor and sexuality coach in the Netherlands and member of 2 advocacy groups, one in the Netherlands, one in Germany, and a member of the steering group of ERN. And I have no conflict of interest, and just like Irene, I will not go into all the aspects of sexuality. Marieke and Stefano already did in the first edition. So I want to share the patient perspective with you, and I want to present some examples. The road I went, somewhere down at the hill it was about 35 years ago when I first sat down with a group of ERN adults. And the goal was not to talk about all the surgeries they had, because they were doing that all the time. The idea was to talk about the everyday life. At that time, one of the biggest challenges was to stay clean during day, at school, at work, and in social situations. And the last topic, the social situations, led to intimacy and sexuality. A woman told, as an example, a woman said, "No way I'm going to be naked in front of a man. I must look awful down there." And another boy said, "I cannot be intimate with someone." So how does it look talking about sex in a group? First of all, the need for respect and privacy. It's very important to mention. Everything that was said stays in the room. Sometimes a little bit of education is needed to bring everybody to the same level of knowledge. And like Irene already said, it's important to agree on which words are used and which are not appropriate or not wished for. And then we talk about several aspects of sexuality, and most of the aspects or topics are brought up by patients themselves. One of the most helpful parts is role playing. We often do that. And for instance, how do I tell my partner about my condition? How do I explain my incontinence? What words do I use? And one of the biggest power of working in a group, in this case ARM patients, is that they all know by experience what it means to be incontinent and how inconvenient and embarrassing life can be with this ARM thing to cope with. Well, I also have conversations and interviews in private with patients, and important to mention that it's not my goal to solve the problem for the patient. It's my task to empower them so they can create their own solutions. When it feels awkward, it's okay to share this. Feeling awkward isn't that bad. I explain my confidentiality obligation, and I explained a little about the interview we're going to have. And it's important to mention that there are no things like silly things or taboos. We can talk about everything. A short note in between, I learned there is so little knowledge among average people and ARM patients about their own bodies. I really think it's shocking. They don't know hardly about the functioning of the sex organs. How do they work? A lot of people have no idea how they look down there. Then I have an example for you. A man, 26 years old, born with ARM and no other anomalies. He said he couldn't have intercourse because he couldn't maintain an erection. When I asked him, he told me he could have an orgasm and he could ejaculate. I first advised him to see a urologist, and second, we talked about having sex without intercourse and how he could pleasure his girlfriend anyway without intercourse. In the beginning, he was a little bit ashamed hearing me talk in such an open way. His shame rather quickly was gone, and he started asking more questions in detail. And 4 weeks later, he called me and he said he practiced the alternatives and he and his girl were very happy with it. And a week later, he was on the phone again and he had visited the urologist and he got a prescription for tadalafil and that was working too. So at the end, he was happy and his girlfriend seemed happy too. Then one time I was visited by a young couple. The young man was born with ARM, also no other anomalies, and she was perfectly healthy. And she told me when they had sex, he rushed into the bed. They had sex and he left immediately within a few minutes, leaving her behind unsatisfied, feeling unwanted and undesirable. So we talked and he explained that he didn't want to explain more in presence with his girlfriend. So we decided to talk, the two of us, and then he explained to me he was so incredibly anxious to lose stool when he was fully naked in bed, and he didn't have the courage to bring this up, this topic. And I tried to find out why not, why he didn't want to tell it. And then came out, he wanted to tell, but he didn't have the right words, or he couldn't find the right words to it. So I started doing role playing with him, and we practiced word for word and finding a way that was acceptable for him. And then in the second session, his girlfriend was with him and he could explain and tell her. And she was incredibly enlightened that she wasn't the reason for his behavior. That was in her head. Maybe I'm not good enough. So that was already a big relief. And she understood what he said. I gave them a few tantric exercises to be intimate without having sex, without being fully naked. And we also talked about what could go wrong and how bad this would be. And his girlfriend shared her ideas about his incontinence and said it was not a problem for her at all. Later, they told me things got better, not perfect, but they were on their way and it improved every time again. And then there's this cute example of a very young woman, 14-year-old, born with cloaca, and she was pushed literally through the door by her mother, and her mother slammed the door, and there she stood, the poor thing, with panic in her eyes, and she blushed and sat down. And the first thing I did was asking if she wanted to stay. If not, she was free to leave. I do not want conversations or interviews on this delicate topic with people who don't want to. But she nodded yes, that she wanted to stay. And so I suggested I first would tell a little bit about me and what I'm doing and what we could discuss about. And I asked her if it was okay that I asked her some questions. And she nodded yes. She didn't say a word until then. And after a lot of questions, where she could shake her head or nodded, she didn't say a word. She was too ashamed. It came rather clear what was going on. A surgeon had told the parents she needed a redo for her neo-vagina, and she wasn't sure about it. And then I explained a few things about intimacy, sexuality, intercourse, and checking every time again if the words I used were okay for her. I didn't want to frighten her. Until that moment, she hadn't said a word. I gave her a piece of paper and a pen. Write down some questions for the surgeon and for your parents. What do you want to know and what is difficult for you to talk about? And she wrote down for the surgeon the question if it could wait. Was it necessary to do the operation at this time, or was it possible to wait? And what were the consequences if she waited? Because she felt she was too young for such an important operation. And the question for her parents was, she wanted to know why the parent thought it was a good idea to do the surgery now. So with these two papers, I thanked her for her courage and trust in me, and she smiled and left. And it was very cute. Later in the afternoon, before they went home, she came to me and gave me a big hug and said, "Thank you so much." That was really cute. Well, is there a difference between so-called healthy, normal people and people born with ERN in concerning sexuality? And I think there is. People with ERN, and that's the left chicken, they often look at the other people as if they are free from any problems concerning sexuality. And the other people would be then the little chicken with the beautiful feathers on its head. And often in my talks, I explain that a lot of the so-called sexual issues, sexual problems are just a result of being human. So it concerns thousands and thousands of people, also a lot of people born without ERN. Still a significant group, like earlier said, suffer from negative body image and not functioning sex organs and incontinence. In that way, people with ERN are one step behind compared to others. And like Irene also said, and I want to express that once again, it's important to have the proper counseling. Then taboo or do. As far as I'm concerned, there are no taboos during the interviews I have. And also not during the group talks we have. That's one thing I have to mention. Of course, there's a thing like law, religion, and society. You have to, or you cannot ignore that. And I personally draw the line when law is to be broken, and I always be clear about that. Other things can be spoken about. In other words, there are no taboos. So a lot of things we talk about, and I think one of the most important is humor. Sex can be funny, so it's not forbidden to laugh. Then we come to responsibility from patients. I think it's your own body, it's your own mind, so your problems belong to you. For example, get educated or go to the doctor. And very important one, stop whining and do something. And that's my experience, that some fellow patients only whine and do nothing and complain and still do nothing. So I really try to empower them so they can make the steps themselves. And then the responsibility for caretakers. Please don't look away. Bring up the subject and use your knowledge. I think you caretakers know more than enough to have good conversation about sexuality with your patients. At least the physical aspects of everything. And in your hospital, agree upon who does the interviews and look after there will be a proper documentation who does it, and please document the interviews also. So I've been talking with more than 150 people born with ERN, cloaca Hirschsprung, and cloaca extrophy. But it all started in Rotterdam when I was 12 years old. I myself was also born with ERN, and my pediatric surgeon said to me when I was 12, Michel, I want to talk about sex with you. And I said, no, we're not going to do that. I'm too much ashamed. It's not a topic I want to discuss with you. And next time when I was there, he again said, well, let's have a talk about sexuality. And I said, no. I don't want it. I don't want to talk, discuss it with you. And when I was 14 and started to have some questions about this topic, I exactly knew who to call and who to go to. So for me, it was very helpful. It was a very positive experience. I've got a little take-home message, or more a question you can think about. More than once, doctors told me they were too embarrassed to talk about sex. Way too awkward, they say. But I really wonder, when you ask boys, girls, adolescents, and even adults about a stool, how often they go to the toilet, the color, the form, the density, small or big, and then without a blink of an eye, you go to bladder, urine, etc. And then you say you want to have a look at their anus and maybe feel inside. And when you do that almost every day, how on earth is it possible to say talking about sexuality is embarrassing and awkward? Again, thanks for having me, and it was a pleasure.
Thank you very much, Michel, and Irene. You can come to the webinar environment if you would like as well. Thank you so much. I would like to open a discussion. So if you have any questions, you can type them in the Q&A section. So if you hover over with your mouse underneath, you can find a tab with Q&A. So type in your questions and then we can discuss them. In the meantime, I would like to take this moment to mention that all our webinars are recorded. So this webinar is recorded as well. Yeah, great, Michel, thank you. So this webinar is recorded as well. I will send the link for the recording tomorrow via email to everyone that had registered for the webinar. And we will also put it on our YouTube channel. So make sure you follow us on YouTube so you can see all our webinars. We have a list of our different webinars on there as well. So if you're interested, you can find everything over there. Lastly, we send out a survey through Zoom after the session has finished. So if you could fill that in, we can continuously improve our sessions. I don't see any questions in. If you're not able to type in your question, if you do have a question and you cannot find the Q&A section, you can always raise your hand and then I can see if I can open up your mic. So maybe we can have a live discussion if you like. But in the meantime, it was very interesting. Thank you so much for the presentations. Really enjoyed it. I think it's a very important subject within our field.
Thank you.
Oh, yeah. Let me see. Yeah, I can see somebody says no question, just a thank you. So I think it was very clear. And if somebody has a question, you can always email me and I can pass them through or bring you in contact with somebody if you like. Yeah, so I think that was it. I think it was very clear and everybody enjoyed it. So thank you all.
Thank you.
Have a nice evening, everybody. Thank you to the attendees for joining, and we will see you on our next webinar.
Okay, thank you.